Okay, so chest tubes. What's the purpose? Why are we using them?
To get secretions out of the
Please stop it.
lungs.
That is not true.
That is when you have like a hole and you don't.
Hemothorax.
Yeah.
Oh, hemothorax, pneumothorax. So this is air or blood in the pleural cavity, not in the lungs. If we poked a hole through the lungs, they would be dead.
Is that atelectasis?
No, atelectasis is when the bottom of the lung sticks. Okay. So this is when they have like a accumulation of blood. Maybe there's a gunshot wound, a stabbing, a something, some kind of trauma, and now blood has filled up either the pleural cavity or in the chest cavity, and it collapses the entire lung or partial collapse. Okay. In that case, you have to stick a tube in from the outside inside, right? To evacuate all of that stuff so that the lung can re-expand or reinflate. Do you understand? Okay. So chest tubes are supposed to be done by an NP or a physician, but your job is to get them ready for the chest tube. Okay. How will I know a patient needs a chest tube?
Difficulty breathing, or is it going to be kind of like obvious if it's like a gunshot wound?
It won't be. It won't be obvious. I mean, you can see a gunshot wound, but how do you know that their lung collapsed on that side?
Is it gonna be
Absent breath sounds on that side. I'm worried about y'all. Absent breath sounds on that side. Yes, they're going to have difficulty breathing, but you won't hear anything because that entire lung has collapsed, like shrunk up. Do you understand? Okay. If it's a really bad one, then the trachea is going to
Shift.
deviate to the
right side?
contralateral or opposite side, right? Because if, let's say I got shot here, okay, that's going to make a hole. Air went in. Right? Now all this air is trapped in this space. My lungs need a very specific amount of pressure in order to inflate. Well, it pushed air in there. So it's going to completely collapse my lung right here, which is going to push everything over here in my airway. So if you see a deviated trachea, who's in trouble? Okay? That's a really bad one. All right? So that means the whole lung is collapsed. I'm going to be breathing really hard and have difficulty breathing. And they need to come in and poke a hole so that all that air that's trapped in there can now escape. And then my lung can reinflate. Do you understand?
Mm-hmm.
All right. So
basically a chest tube is, we got to be more specific than just poking a hole, let the air escape. We have to actually make sure we get all the air out.
Yes, and it's a very specific spot, and the doctors will know like which rib in order to go into. And I saw this when I was a nursing student for the first time, and it was incredibly traumatic. It is not a pretty procedure. It is not cute. It is not sterile even really. They can do it at the bedside because it's emergent, right? It is rough. So what they do is they make a very rough incision. Okay, a lot of times they don't even have time to sedate the patient. So they're just cutting into the patient, okay? And then they can't cut all the way through because they don't know where the lung is, right? They don't want to puncture anything. So they cut down to basically what looks like the fascia or the muscle layer down there. And you're ready for this? It's gross. They stick hemostats, hemostats, the little scissors, inside the hole and open it and go like this to open the hole, okay? Then they stick their finger in there to make sure they have penetrated all the different layers. And then they're like, okay, we're in. I mean, and the first time I saw it, it was a homeless woman. It was an emergent situation. They were doing it bedside. They gave her nothing. No pain meds, no sedation, no nothing. And just got all the nursing students in there to hold her down. It was so mean. She's screaming at the top of her lungs, get off me. Because they're literally cutting a hole into your cavity. I mean, it's awful. So it's not an easy procedure by any means. So once they get in there, then your job was already to set up the sterile field. This has to be sterile, obviously. Okay. Sometimes it doesn't look that way, okay, but you're supposed to set up a sterile field. Then the doctor or the nurse practitioner is going to grab the chest tube and they shove it into that hole, and then you need to stand back because as soon as you shove it into that hole, what's coming out the end of the tube? Air, blood, whatever, and it will spray, and it did spray everywhere. So because a resident did it and he did a very bad job because they're very nervous when they make the first incision. So when he made the first incision, he didn't make it deep enough. So the doctor's like, you need to make it. So he had to go back and cut her again and cut her again. It's rough. When I thought of a chest tube, I'm like, oh, it sounds nice. They're going to put a little hole in it. And it ain't like that. Okay. It was rough. So anyway, so once they get the chest tube in there, now it's your job. Everything else from here on out is your job.
Keep it suctioned.
All right. So they usually will suture it onto your patient so that it doesn't move because it's real easy to pull out. We don't want that. And it needs to be in a certain spot, right? And you'll understand this is not inside the lung. It's inside the chest cavity. Okay. So once it's in there, they'll usually suture it to your patient. Now, it can still pull, so you need to keep them in a certain position, right? And then the other end of the tube is going to connect to this unit right here. Okay? Which you're going to do it like you would do like a Foley cath. You want to make sure that the unit, the chest tube unit, is always below the level of the patient so that it can drain. Do you understand?
Mm-hmm.
Yes.
Okay. So here it says, before inserting, give pain meds and sedatives. You are supposed to do that because it's going to hurt like hell. But in an emergent situation, they may not be able to do that. But you should try because it is very painful. Okay? Tubes come in various sizes, but the doctor will be able to choose. And you'll know tubes come in French sizes. They're called French, right? So they'll say like it's a 6 French, 7 French, 8 French, whatever tube.
Oh,
Y'all know this now?
yes.
Okay. So, and that's pretty much every tube. That's not just chest tubes. You see, like this one is a feeding tube. This is wait, hang on.
I believe that one is French too.
Everything is a French tube. Everything you'll see is French. This is a feeding tube. This is not a chest tube, but you'll see it says on here 10 French. So all of your sizes of tubes will say FR, which is French. Okay? It's not in French. You understand? Yeah?
Yeah.
So the bigger the number, the bigger the size, okay? So that way when y'all go into the hospital and they say like, oh, hey, can you bring me a 10 French feeding tube? You're like, oh my God, yes, I know exactly what that is. Okay? Yeah?
Yes.
Okay. So they're going to put it in, and you need to keep it as sterile as possible. Is that going to happen? Probably not, but that is your job, is to try to keep it as sterile as possible. Expect a chest x-ray to be ordered every day because we want to make sure the tube is in place. We want to make sure the lungs are inflated, okay? They can have a chest tube next to or in the parietal space of every lobe of the lungs if they have to, okay? So you can either have it just in the chest cavity or you can have it in the parietal space. There's 3 on one side, 2 on the other. Yeah. All right, there are 3 chambers and you need to know what to expect and what to monitor in each chamber and what is abnormal. Okay, so first of all, we are suctioning out of this patient. You're suctioning air and you're suctioning blood out of the patient. Okay, so you're gonna have a suction chamber. Duh, okay? What you should see is gentle, continuous bubbling, okay? Because you have to have some water in there. It's not the water cell chamber, but you have to have some in order to suction correctly, okay? Because you've got to have something to suction into, right? So you should see gentle, continuous bubbling. If they ever ask you in a chest tube question and say that something is vigorous, that is never going to be your answer. We don't want vigorous anything happening with the chest tube, okay? No vigorous. Be gentle. Okay, settle yourselves down. All right. So the suction, you usually will do an intermittent suction because continuous suction can just irritate, right? So it'll usually be just kind of intermittent here and there. All right, you with me?
Yes.
But which
Okay.
one is the suction chamber?
They're all labeled,
This one?
sister. Suction control, you see where the suction control regulator is?
Yeah.
And then underneath
The
that, you'll see
air
the
leak
suction
monitor?
monitor.
The air leak monitor? No?
No, the suction, where it says suction.
Okay.
Okay, and then the suction port is where you attach the chest tube. Okay, so the suction is going to typically be intermittent, and we do not want high levels of suction because it can get stuck to the lung. It can get stuck to the inside. We don't want that. So
basically, like anything with suction, like actually in a place that's going to be long term, you want it intermittent.
usually, yeah, because just continuous suction is just too irritating. Okay, all right. So you understand what you want in suction.
Yeah.
What do you want in the suction chamber?
Bubbling.
Gentle, continuous bubbling. Because you think like when you're suctioning something, it sounds bubbly, right? Like blow bubbles in something. Okay, so there should be bubbling in there. Do we got it?
Yes.
No vigorous.
No bigger.
No vigorous. Okay. Then you have the collection chamber. That's where all of the blood and all of the whatever fluid is in there is going to be collected. Do you understand?
Yes.
Yes.
Okay. And then you will have a water seal chamber. This is what kind of seals the deal so you don't get any air leaks. Okay. So in a seal, if something is sealed, do you expect to see bubbles in it? No, if you saw bubbles, you'd think it was leaking.
Yeah.
So if you see bubbles in the water seal chamber, that's not normal. There's probably an air leak. Does that make sense?
Yes.
Okay. So in the water seal, you're going to use 2 centimeters of sterile water, and you do need to know that. Okay. It needs to be 2 centimeters of sterile water. That's going to seal in the chest cavity and prevent air from getting in. Okay. If there's bubbles in the water seal, what does that tell you? There's a leak. What you should see in the water seal chamber is gentle titling. Write that in there. Gentle titling. It should go up and down. Up and down. Up and down. With every breath you take in. So it's going to seal it in one way when you inspire and seal it at the low end when you expire. So you're just going to see these nice, gentle waves called titling. You breathe in. Do you want to see vigorous titling?
No.
No, I do not. Okay? So everything in your chest tube you want to be gentle. Sounds nice, doesn't it? Indeed. All right. So if you see bubbles in a water seal, what should you do?
Check for leaks.
Look for a leak. Look for a leak. Do you understand?
Yes.
Okay. All right then. So as far as nursing care, make sure you keep the collection chamber down below the level of the patient. Otherwise, it's not going to drain. We tape the base to the ground. So that way somebody doesn't get tripped up on it, doesn't pull out the chest tube because they tripped or they got stuck on something. So you tape it to the ground. Do you understand?
Like in this picture, like that thing that's sticking out, you would tape over that? Is that what that
Yeah, you can tape over that. Yes. Okay. Or they may just, you know how you wrap tape in a ball? They can do that too. Okay. All right. If there is a massive color change or drainage change, you need to notify the provider. So you need to watch their output, and that goes on their eyes and nose sheet. Any chest tube output goes on there. If you all of a sudden see a huge amount when you didn't before, that's a red flag. You need to notify the physician. If they were staying consistent at a certain amount and all of a sudden there's none, what's the first thing you should do?
check the leak?
Breathing
Do you think it's a leak?
Oh.
Huh?
Can be breathing sounds. They can be accumulating.
You could check the breath sounds to see if the patient has gotten another pneumothorax, but it's probably that the tube is just not positioned very good. So just reposition the patient, and what you'll usually see is all of a sudden, just because they were kind of sitting in a weird way. Yeah, so reposition the patient whenever you're not seeing drainage and you would expect to, and it usually will clear it up. Just kind of, turn them in a different way, okay? All right, moving on. If the tube gets pulled out, now there's two different places the tube could get pulled out. It could get pulled out from your patient. If the tube gets pulled out from your patient, now there's a giant hole. What's the first thing you should do?
Sterile gauze with a three-way. Is it a three-way or a four-way?
three-
Occlusive dressing.
Oh, okay, so a three-sided
Occlusive dressing.
occlusive petroleum jelly gauze. Oh, that's a mouthful. Three-sided occlusive petroleum jelly gauze. What that means is it does actually have four sides. Okay, so this isn't it, but I'll show you kind of, at least so I can show you something. Oh, by the way, this is the little trait guy. Okay, but anyhow, so it'll be a little bigger than this. It does have four sides like this, but this side, and this side have petroleum jelly on it. You know what that is, right?
Yeah.
Okay, because we want it to stick to the patient. One side does not have the petroleum jelly on it. So we want to basically plug up the hole so that nothing can get in it. But if there's air trapped in the chest, we want one side that doesn't have the petroleum gauze so that the air can escape out. Does that make sense?
Yeah.
Okay, so it's called a three-sided occlusive petroleum jelly gauze. And that's the first thing you would do for a chest tube that came out. Do you understand?
Yes.
Okay. If the tube comes off of the collection unit, what do you do?
You put it back in.
You can try to put it back on. If for whatever reason it's broken or you can't get it back on.
You put it in a bottle of sterile water.
Yes, you're going to put it in a cup of sterile water because it needs to be water sealed. Otherwise, air is going to get back in it, right?
Yeah.
So that's very temporary, and you're only going to do that until somebody can come and help you and you can get it put onto a new collection device. Are we clear?
Good.
Okay.
So the 2 centimeters of sterile water, you don't count that as an INO because you're adding. That
No, and it will evaporate a little bit over time. So it does not. It's not actually going into the patient. It's just sitting, kind of like our cup of water sitting in there. That's all it's doing, is sealing something. Oh, I meant to tell y'all too. Go back to the drainage. I didn't write this down, but write it down. In pediatrics, if they have more than 5 mLs per kilo of drainage in 1 hour, or I'll say it twice, more than 3 mLs per kilo in 3 consecutive hours, that's a red flag amount of drainage, because that's a lot, right? Like, let's say the kid weighs 10 pounds, baby, right? That means they're like less than 5 kilos. They would have 25 cc's of drainage. That's like half a baby, That's a lot. So if they have greater than 5 cc's per kilo, not 5 cc's, but 5 cc's per kilo in an hour, or greater than 3 cc's per kilo per hour for 3 consecutive hours, some places will tell you 2 consecutive hours, just depends on hospital policy. That is a red flag. That's a lot of drainage and something is going on. Okay?
Greater than 5 cc's per kilo.
Per hour. 5 cc's per kilo per hour.
And then the other one was
3 cc's per kilo per hour for 3 consecutive hours. Y'all with me?
Yeah.
Okay. Highlight. Never clamp a chest tube. Never clamp a chest tube. Yeah. The only time you are ever allowed to just clamp it, okay, is if you see maybe there is bubbling in the water seal chamber. What does that tell me?
Leak.
There's a leak. So I can clamp it for like a few seconds to see if I see any immediate leaks in the tube or leaks coming out of the patient or leaks in the collection chamber, and then I unclamp it because you're changing the pressure. So you should never clamp it. Don't pick an answer that says,
Clamp.
oh, clamp it while the patient goes to the bathroom. Whatever. No, we want to drain. Okay, we want it to drain. Okay, never milk the tube. Never milk the tube. They used to do this all the time. They would take the tube and like if they thought it was if they thought it was occluded or something, and like strip it like this to get the clots out or whatever. But then every time you do this, it's clamping it basically, right? So you don't milk the tube. All right, then.
Yeah.
You still want the patient to turn, cough, and deep breathe. Sometimes people will be afraid to pick that on an exam because they think, oh, you don't want them to cough it out. I done told you they sutured it in. Oh.
Yeah.
So you still want them to turn, cough, and deep breathe to prevent atelectasis and pneumonia. Yeah?
Mm-hmm.
Are they positioned in a certain way?
You're going to turn them. I mean, they can still turn. And you may have one chest tube in a patient. You may have two, but we still have to do all of the normal turn, cough, deep breathe, all of those things to make sure the lungs stay healthy. Okay? All right. Do you understand chest tubes?
Yes.
Do you understand what should and should not happen?
Yeah.
Yes.
Don't milk it.
Don't ever pick something that says, oh, you have a problem with the chest tube. Turn up the suction. No. That doesn't sound right? Like if there's a problem with the chest tube, probably your first thing to do is not to increase the suction. Most of the time, if they tell you that they think there's something wrong with the chest tube, you want to auscultate the breath sounds first. And that's to see if there has been a new pneumo or if they've got two, healthy, not unhealthy, but at least pretty good lungs that you can hear breath sounds, then it's something going on with the tube or the collection device. Okay?
Mm-hmm.
All right. You know how to troubleshoot a chest tube. I just taught it to you.
Yeah.
So, okay. All right. Questions?
No.
Okay.